Man, I find this confusing. So hard.
Maybe me and Ryan can help you about our topic. Okay, let's start. You look confused. Is there anything I can help?
Yeah, please.
How it's going, boys and girls? Now, in this video, let's talk about the respiratory system to look for its function, components, and how the system works. The structure of the respiratory system is uniquely suited to its primary function, the transport of gases in and out of the body. In addition, the respiratory system provides a large volume of tissue that is constantly exposed to the outside environment, and thus to potential infection and injury. Finally, the pulmonary system includes a unique circulation that must handle the blood flow. The anatomy of the lungs. Airflow through the respiratory system can be broken down into three interconnected regions: the upper airways, the conducting airways, and the alveolar airways. The upper airway consists of the entry system, the nose, and the mouth that feeds into the pharynx. The lungs extend from the lower part of the pharynx to complete the upper airway. The nose is the primary point of the entry for inhaled air. Therefore, the mucosal epithelium lining the nasopharyngeal airways is exposed to the highest concentration of inhaled allergens, toxins, and particulate matter. With this in mind, it is easy to understand that in addition to olfaction, the nose and the upper airway provides two additional crucial functions in airflow. The conducting airway. The conducting airway begins at the trachea and branches dichotomously to greatly expand the surface area of the tissue in the lung. The first 16 generations of passages form the conducting zone of the airways that transport gas from and to the upper airway. These branches are made out of bronchi, bronchioles, and the terminal bronchioles. The conducting airway is made up of a variety of specialized cells that provide more than simply a conduit for air to reach the lung. The epithelium is organized as a pseudostratified epithelium and contains several cell types, including ciliated and secretory cells that provides key components for airway immunity, and basal cells that can serve as progenitor cells during injury. As the conducting airway transitions to terminal and transitional bronchioles, the histologic appearance of the conducting tube changes. Epithelial cells in the conducting airway can secrete a variety of molecules that aid in the lung defense. The alveolar airway.
Between the trachea and the alveolar sacs, the airways divide 23 times, and the last 7 generations form the transitional and respiratory zones where gas exchange occurs are made up of transitional and respiratory bronchos and alveolar ducts and alveoli. These multiple divisions greatly increase the total cross-sectional area of the airways. The alveoli are lined by two types of epithelial cells. Type 1 cells are the flat cells with large cytoplasmic extension and are the primary lining cells of the alveoli, covering approximately 95% of the alveolar's epithelial surface area, while type 2 cells or so-called the granular pneumocytes are thicker and contain numerous lamellar inclusion bodies. Although these cells make up only 5% of the surface area, they represent approximately 60% of the epithelial cells in the alveoli. Type 2 cells are important in the alveolar repair as well as other cellular physiology. One prime function of the type 2 cell is the production of surfactant. Typical lamellar bodies, membrane-bound organelles containing whorls of phospholipid are formed in these cells and secreted into the alveolar lumen by exocytosis. Tubes of lipid called the tubular myelin form from the extruded bodies, and the tubular myelin in turn forms a phospholipid film.
The respiratory muscles.
The primary muscles. The primary inspiratory muscles are the diaphragm and external intercostal. Relaxed normal expiration is a passive process and happens because of the elastic recoil of the lungs and surface tension. Accessory muscles. The accessory inspiratory muscle are the sternocleidomastoid, the scalenus anterior, medius and posterior, the pectoralis major and minor, and the inferior fibers of the serratus anterior and platysmus dorsi. The serratus posterior and anterior may help in inspiration, also the iliocostalis cervicis. While the accessory expiratory muscle are the abdominal muscles, the rectus abdominis, external oblique, internal oblique, and transverse abdominis. A decrease in intrathoracic volume and forced expiration result when the expiratory muscles contract. The internal intercostals have this action because they pass obliquely downward and posteriorly from rib to rib, and therefore fold the rib cage downward when they contract. Contractions of the muscle of the anterior abdominal wall also aid expiration by pulling the rib cage downward and inward by increasing the intra-abdominal pressure, which pushes the diaphragm upward. In order for air to get into the conducting airway, it must pass through the glottis, defined as the area including and between the vocal folds within the larynx. The abductor muscles in the larynx contract early in inspiration, pulling the vocal cords apart and opening the glottis. During swallowing or gagging, a reflex contraction of the adductor muscle closes the glottis and prevents aspiration of food, fluid, or vomitus into the lungs. In unconscious or anesthesia patients, glottic closure may be incomplete and vomitus may enter the trachea or the windpipe, causing an inflammatory reaction in the lungs that is called aspiration pneumonia.
The lung pleura. The pleural cavity and its infolding serve as the lubricating fluid that allows for lung movement within the thoracic cavity. There are two layers that contribute to the pleural cavity: the parietal pleura and the visceral pleura. The parietal pleura is a membrane that lines the chest cavity containing the lungs. The visceral pleura is a membrane that lines the lung surface. The pleural fluid, 15 to 20 ml, forms a thin layer between the pleural membranes and prevents friction between surface during inspiration and expiration. The lung itself contains a vast amount of free space. It is 80% air. Although this maximizes the surface area for gas exchange, it also requires an extensive support network to maintain lung shape and function. The connective tissue within the visceral pleura contains three layers that help support the lung. Elastic fiber that follow the mesothelium effectively wraps the three lobes of the right lung with the two lobes of the left lung. A deep sheet of fine fibers that follow the outline of the alveoli provide support to individual air sacs. Between these two separate sheet lines connect to tissue that is interspersed with individual cells for support and lung maintenance. First is the inspiration. It is an active process. Contraction of external intercostal muscles and relaxation of internal intercostal muscles occur. The rib cage moves forward and outward. The diaphragm contracts and becomes flattened. Increase in volume of the thoracic cavity. Air pressure in lungs is less than atmospheric pressure. And intake of air into lungs.
Inspiration is the active process, expiration is a passive process. And the second difference is the relaxation of the external intercostal muscles and contraction of internal intercostal muscles occur. Then the third difference is the rib cage move downward and inward. And next is the diaphragm relaxes and becomes original dome shape, and there's a decrease in volume of thoracic cavity. And the air pressure in lungs is greater than the atmospheric pressure, and lastly, expiration is an expulsion of air from the lungs.
Lung volume and capacities.
There are four various respiratory volume. This is the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and the residual volume. The first one is the tidal volume, which is about 500 ml, and it is the amount of air inspired during normal or relaxed breathing. The next is the IRV, the inspiratory reserve volume, about 3,100 ml, and it is defined as the additional air that can be forcibly inhaled after the inspiration of the normal tidal volume. The next one is the ERV, or the expiratory reserve volume, about 1,200 ml. It is also defined as the additional air that can be forcibly exhaled after the expiration of a normal tidal volume. Then the last one is the residual volume, about 1,200 ml. Is the volume of air still remaining in the lungs after the expiratory reserve volume is exhaled.
The next one is the total lung capacity, or the TLC. It is about 6,000 ml, is the maximum amount of air that can fill the lungs, followed by the vital capacity, or the VC, about 4,800 ml. It is the total amount of air that can be expired after full inhaling. The next one is the inspiratory capacity, or the IC. It is about 3,600 ml. It is the maximum amount of air that can be inspired. And finally, the functional residual capacity, or the FRC. It is about 2,400 ml. It is the amount of air remaining in the lungs after a normal expiration. Did you know some of the air in the lungs does not participate in the gas exchange? Such air is located in the anatomical dead space within bronchi and bronchioles, that is outside the alveoli.